And I think it gives you like a little message that you're now being recorded. Okay. Let's see. Don't know if I can keep the chat open at the same time. That's the hard part, doing these on your own. Nobody to watch the chat. There we go. Okay, now I can see the chat. Okay. Can you see the week 10 hormone regulation? Is that what's on your screen?
Yeah.
Yeah, thank you. If you have questions, I don't know if people have questions. Are there specific things that you would like me to focus on, or what is your pleasure? Because what I was going to do was kind of just go through the tabs here, kind of do a review of the endocrine system, and then move into the thyroid peds disorders. There's just like growth hormone is the only one we're going to review, and then the thyroid and parathyroid disorders. But if you have specific questions, I'm happy to try and answer those or go in that direction if you prefer.
Whatever is most helpful for the finals is good for me.
Got it. Okay. So you do have the study guide that I handed out, and I did attach it. Oh, thanks, Kat. I did attach it to the meeting. I do have a more I do have a study guide that has more information on it than what that had. So when this is over, I can put that out there for you to look at. I'm just looking. You know, I have two screens on at home. Isn't that kind of embarrassing? I have two screens at home, not just at work, but at home. Or let's see. Actually, let me do this. Hold on. Let me save this, and I'll add it to the module. Oh my goodness, sorry. Yeah, that's when she's barking. You all think she's quiet and just, but no. Well, that's the other dogs are going nuts. Hold on. Let me save this. Okay, let me upload it into the module because it's got more information. Hey, come on. All right, fine, be that way. Because it's got more information and you might want to take notes on it, I'm thinking, than the one that I gave you. So not assignment, we want file. Create file. I'm sorry. I should have uploaded this sooner. That is not what that is what I want. So this will upload to week 10, which is where the thyroid information is, the hormone regulation. So I would put, it says updated study guide hormone. Hey, you. Come here. I know you had a long day, huh? So did everybody else. Excuse me. Okay. So let's go back to the page. What? Hello. All right. Can you see the hormone regulation screen again?
Yes.
Yes, thank you. And then if you go into if you refresh and go into the module, you'll see the updated study guide notes there. Okay. So don't care about that. All right. So endocrine system. Is there anything you in particular remember anything at all about the endocrine system?
Diabetes.
Diabetes, yes, diabetes, because you guys got that a lot in first semester. We've done it a lot here as well. What specifically about like what are the components of? What are parts of? Like we have a couple pictures here. What do you remember anything about like the hypothalamus? Yep, thyroid and adrenaline gland. Yep, and where your adrenals are on top of your kidneys. Do you remember what the hypothalamus does? The hypothalamus has the releasing hormones. And so if the hormone levels are low, then it's going to release hormones, release the stimulating hormones. And then when you are in the pituitary, you have the anterior and posterior. Anterior and posterior pituitary, there you go. And so that's where these different hormones are coming from. So when we think about, so we're going to talk about growth hormone a little bit. We're for sure going to talk about TSH, the thyroid stimulating hormone. Those are the ones that we're going to focus on. We're also going to talk a little bit about oxytocin because that has to do with the breastfeeding. And what I wanted to do is show you examples of what a negative and positive feedback loop are. When we're talking about hormone therapy, because that's basically what's happening is the levels of the hormones, there's a feedback loop that gets back to the hypothalamus that then decides, oh, do I let out more releasing hormone, which then goes to the pituitary. Oh, do I let out more stimulating hormone or do I need to not do that? So for example, with oxytocin and breastfeeding, that is considered a positive feedback loop. So positive feedback loop, for example, the baby is sucking at the breast. The pituitary releases oxytocin, which the milk producing cells then send milk to the ducts and milk is released from the nipple pores. So what happens is the baby sucks, it sends a signal and you get more milk. And the more the baby sucks, the more milk you get. So that's a positive feedback loop. The baby stops sucking. It's not a negative feedback loop, but it'll stop, right? Because the baby's not sucking. And so the pituitary, the release of oxytocin isn't there anymore. And so the baby will empty the breast and be done until the next feeding. So that's positive. And then if you're looking at a negative feedback loop, for example, that one's not very big. What are you growling at? Knock it off. And so, for example, we're going to look at a negative feedback loop. So if you have blood glucose here at number 2, the blood glucose is low. And so the pancreas is going to release the glucagon to help increase blood glucose. So blood glucose goes up. And then the pancreas will decrease the secretion because the blood glucose has gone up. So you've gone from a negative, it's a low, we did something which now makes it high. Whereas with the oxytocin, there wasn't a low, there was oxytocin there. We're just making more oxytocin and more oxytocin. But with the blood glucose being a negative feedback loop, there's low glucose, the sugar gets released from the liver, and the blood glucose goes up. And so then the gland decreases the secretion. And so it's just, I think, important to know, and this is the opposite of that. So it's still a negative feedback loop. So you eat your burger that has a lot of carbs in it, the blood glucose goes up. So the pancreas stops the insulin secretion and the glucose goes down. And so the pancreas is then not going to release more insulin secretion, right? Because we got the sugar down. If we keep doing insulin, the blood sugar is going to drop again. So that's a negative feedback loop because we start one way and end another way. Does that make sense? Thumbs up.
Yep.
Yes, thank you. So that's why I like to go over that because that's one of the main components of what happens with your hormones, with the endocrine that we're going to talk about. I like this little quick and short kind of diagram. Basically, for endocrine disorders, you're talking about too much or too little. So it's hyper or it's hypo. And so we're not going to, although we've some people have mentioned, or you might have seen it, DKA, or Addison's Cushing's, those kind of things. We're really at this level going to focus on hypo and hyperthyroidism and hypo and hyperparathyroidism. More on thyroid, but just enough to know about thyroid, parathyroidism, because if you have a low calcium, that can be a problem. And that calcium is regulated by parathyroid hormone. So that's why we're looking at that. And so if you have hypothyroidism, there's not enough hormone, low and slow symptoms. If you have too much, then you can have hyperthyroidism, which would be Graves' disease. Yes, I know. Chill. With me so far? Yes. No, maybe. Maybe. Yes. I also have, yes, thank you, Brenda. Well, I also have my Pinterest, which I think some of you have found. And so I have a whole endocrine section there, hormone regulation. And so if you are a visual person like I am, there's a lot of different pins on that, that can summarize a lot of the hormonal disorders for you. So you have that available to you. Okay, let us go to, let me make that smaller, not so huge. Okay, so we did the endocrine system. Now we're going to talk about pediatrics, because this is part of our pediatrics that we're talking about. And one of the things that can happen is growth hormone, right? We have growth hormone. And so the child can have a growth hormone deficiency or an excess of growth hormone. So it's hypo or hyper growth hormone deficiency. I don't know if anybody at Coastal Kids maybe has seen a child with this. There can be different reasons for it. You can have tumors or different disorders, or it can just be a problem with the pituitary. It's usually some kind of tumor, but it can just be a decrease in the growth hormone. And so the baby doesn't grow, the child doesn't grow. So they have short stature, potentially dwarfism. And that is not, that's, people live with that. That's not a problem. You can also have an excess of growth hormone, which in children is, I guess you could say, like gigantism. Acromegaly is an excess of growth hormone in adults. So that the example they give for acromegaly is Abraham Lincoln. They say they think he had it because he was so tall, and you have sort of enlarged hands and that kind of thing. But we're just talking about growth hormone deficiency, just so you are aware of that. And you have a couple. She has a really good video. Yes,
Sorry, I have a question about that. So
Alex. Yes.
the big difference between gigantism and acromegaly, besides the fact that they're adults, is when their plates have closed, right? In the bones? Is that like one way
Yeah.
to know when a child has reached that point?
Yes, you have the closure of the epiphyseal plate on the bones, and then there's not going to be more growth after that because the plates close. So yes.
Okay, thank you.
And then I said that we would come back around to congenital hypothyroidism. So that would be when the baby is born with hypothyroidism. And so it can, if we don't catch it, it is one of the things that can be caught on a newborn screen. Again, another reason to do a newborn screen, but there can be a lot of complications from congenital hypothyroidism. I'm not so much concerned about that, but just so you know about it. And that's basically just what I need you to know about growth hormone. There's a deficiency, there's an excess. What is that? What does that look like? A short stature or a tall person? And then if we move on to hyperthyroidism and look at the different facets of that. Again, I have a couple good videos. I'm just looking at my other notes here. Sorry. Oh, there we go. That's what I was looking for. Negative, positive. We did that. We talked about that. We talked about that. Okay, just making sure I'm covering everything that I had in my notes, which we have done so far. So, what would before we get into hypothyroidism, what are some things that might be considered risk factors, not only for hypothyroid, but hormone regulation in general?
Chronic stress.
Chronic stress. Mm-hmm. That will get you to hyperthyroidism. Definitely.
Obesity or a sedentary lifestyle.
I'm sorry, say again.
Obesity or a sedentary lifestyle.
Potentially. I'm in terms of diabetes, I would say yes. Radiation exposure, cancer. So radiation exposure, that's one of the tests for thyroidism that we do is a radioactive iodine study. And so it actually shows if the thyroid is more active or less active. But if you, for example, find out that you have that and then you have a thyroidectomy, that's a problem. You can have other that can lead to like low calcium or like it's like sort of like a cascade. If you have one problem, then you have another. So if do take out the pituitary or take out the thyroid or any one of the glands, that means lifelong hormonal therapy to replace the missing hormones. And that can be a tough, perhaps even isolating, like we were talking about today, socially, having to take a medication for the rest of your life. There's always not always, but genetics plays a part, as in everything. And also you could be born with it, congenital, like we just said, congenital hypothyroidism. Do you know the difference between like primary and secondary in terms of the illness, if it's a primary cause or a secondary cause? So primary cause generally has to do with a defect in the target organ. So if there's a problem with the thyroid, a defect in the target gland, then that's a primary problem or reason for having the deficiency or excess. The secondary would be more in the pituitary or the hypothalamus. So remember, we start up in the hypothalamus and then we go to the pituitary and then we go to the gland. So if there's a defect in the actual gland, like the thyroid, for example, or the adrenals, that would be a primary cause for example, hypothyroidism, because there's a problem with the thyroid. But if there's a problem with the hypothalamus where we started out or in the pituitary, that would be a secondary cause because it's not related directly to the gland itself. Does that make sense? Yes, makes sense? Okay, thank you. Because often when you're looking for causes, thank you, Hunter, you're looking for, is it the gland or where is the problem? So that's why we want to know, is it primary or secondary? And then looking at, okay, so we can look at the hyper versus hypothyroid. So hypothyroid, Hashimoto's, that's an example of of a hypothyroid situation. You have low production of the thyroid hormone, and we tend to think of that as low and slow. Like everything slows down. So there's no energy, you get weight gain, oftentimes you're cold. Dry skin is a big symptom, dry or brittle hair is a big symptom, just like feeling, depression, I guess, as a sequelae of that, but just no energy and weight gain, just not enough of the thyroid hormone. And so when you look at what do you think about how hypothyroidism might affect elimination? Because we were talking about that last week. how would that affect bowel movements, for example, if the person had hypothyroidism?
No peristalsis as a normal person would. So motility is reduced, therefore you have backup.
Yes. Constipation slows down the bowel movement. Very good. Yes. And so that's what I'm saying. It's like a whole systemic problem that happens. And so the heart rate decreases, the blood pressure can decrease, constipation. There you go. And we'll come back to lab values in a minute. If you have too much thyroid hormone, you can get what's called Graves' disease, which is like hyperexcitable, like oftentimes brought on by stress. That's one of the risk factors. Increased heart rate, increased blood pressure, increased GI motility, so lending itself to diarrhea. Weight loss and an increased appetite, always hot, always hot. One of the things about hyperthyroidism that was interesting, because interestingly enough to me, my husband had Graves' disease for a while there, and he actually, I was back in Ohio. He was out here staying with my mom at the time, and she was trying to feed him, and he would not gain weight. She would feed him and take him out and feed him and nothing. And he felt like his pulse, like he was going to jump out of his skin. So when he came back, I said, we're going to the doctor. And I actually was there when they did his radiograph imaging. And it was quite interesting. And so luckily they got him on some medication. And within, I want to say 3 to 4 months, it was cured, I guess you would say. And he's been fine ever since. Hypothyroidism, I don't know. I wish the medicine would help with that. That would be nice. Let's look at lab values and then we'll talk about meds. So we are looking at T3 and T4 and also TSH. So what hormone is TSH? What does TSH stand for?
Thyroid stimulating hormone.
Thyroid stimulating hormone, correct. So if we're looking at, let's take a look at thyroid stimulating hormone, yes. So when you're looking at hypothyroidism, I have less of the hormone. I have less of the T3 and T4. So what happens to my thyroid stimulating hormone? What does the thyroid want to do?
So the hypothalamus will send a signal to increase it, and that's why TSH is up.
Yes, very good. So the TSH, the stimulating hormone, increases because there is a decreased level of the T3 and T4. And so then hopefully by stimulating more, we will make more, the body will make more. But sometimes that doesn't happen. And so then, yeah, upregulate. There you go. And so then we have to take medication. What is one of the first line medications for hypothyroidism?
Levothyroxine.
Levothyroxine, exactly. And do you know which hormone that's supposed to be replacing or taking the place of? Yep, synthroid is the other name. Yes. T4. Very good, William. Yes, T4. So levothyroxine is the replacement for T4. And so they'll do the dosing based on the thyroid stimulating hormone levels and generally start low and work up. Usually you're supposed to take it in the morning. Side effects would be, it's always the opposite, right? So if I'm hypothyroid and I take too much to stimulate, then I might have hyperthyroid symptoms. So that's one of the key things is thinking about thyroid stimulating hormone and when you're looking at the labs. There's all kinds of other tests that can be done, but I'm not worried about those right now. That's when you get at a more cellular molecular level. I just want you to understand that it's hypothalamus pituitary with the stimulating hormone, and then we go to the gland. And then hyperthyroid is going to be the opposite, right? Because the body has a lot of hormone, it has a lot of T3 and T4 in it. So what does the thyroid want to do? I mean, what does the pituitary want to do? downregulate, decrease, right? It doesn't want to have as much hormones floating around. And so it's going to kind of shut down a little. Exactly. And so there are medications to help with that. Propofuril, I can't even say it. We'll just call it PTU. PTU's propylurothiazole. PTU, yeah, thank you. Propylthiouracil. Hey, I was pretty close. Is one medication PTU, and it will help to inhibit the T4 to T3 conversion. And so, because T3 turns T4, I'm sorry, turns into T3, it's counterintuitive, but it will so there's not as much of the T3 floating around because it stops that conversion. There's also methimazole. That's another one. That's a once daily dosing. I'm trying to think what else. You want to monitor, what do we want to monitor? PTU, you want to monitor liver because it gets metabolized in the liver. So liver function tests. We also want to, what do we want to know about the thyroid if we're starting on levothyroxine or on the methimazole or PTU? What are we going to have the client come back and do? Levels, yes, right? Because we have to kind of titrate everything. It's really not something that you can just say, oh, here, take this, and then not come back and evaluate it. However, if the person doesn't come back to the visit, to see the doctor on these follow-up visits, or they run out of medication and don't come back or get a new prescription, then we have problems again, and they will probably show up in the emergency room. And that's the part where I struggle is we can do all this education, and if there's social determinants of health, that are coming into play, it's really hard to help people. What else did I want to tell you about hyperthyroid? Does that make sense? Does that help clarify kind of how that whole cascade works?
Yeah.
Yeah. Petunia, you're just being a PETA. Okay, so then what we want to look at, we talked about lab tests a little bit. We talked about the TSH levels. We talked about the T4, T3 levels. And what else am I thinking? Those are the main ones to know for thyroid. You can also do, I talked about the radioactive iodine uptake. And so you have an increased uptake of the radioactive substance in Graves' disease because it's hypermetabolizing it. It's hyperthyroid. And so it'll take up the radioactive iodine and kind of like just light up all over the place. So that would be one. And then you can do ultrasounds, you can do CAT scans, MRI, the usual, that kind of thing. You can also do different types of biopsies as well. What else am I thinking? Yep, no, that was it. And so just again, those key things, exophthalmos, there's ads on TV now for meds for exophthalmos. Just there's meds for everything now. But this is just another visual for that. Thyroid storm is, what do you think thyroid storm would be?
It's probably just the T3, T4 levels are super high, and there's this cascade of symptoms that come towards the patient.
Yeah. And so it'd be like taking hyperthyroidism to like the top level of like stress and agitation, confusion. It gets so bad that the person can't really function at all. And so we want to get them seen and hopefully treated.
Mrs. Sullinger,
Yes.
would puberty and or pregnancy be an example of a hormonal storm, or is that not quite fitting?
Not the same thing. Um, not considered a storm per se. Hold on, William. Yeah, I will get there. Puberty, the hormones, yes, are increasing. The gonadotropins and all the hormones, but not to such an extent that it's like over too much of the hormones. Same thing with pregnancy. We do have changes in pregnancy, like oxytocin, but it's not to the extent that it is debilitating. When
Gotcha.
you are in a thyroid crisis or thyroid storm, it is debilitating, and it can rise. It will rise, and then we treat it, and it will come back down. So it goes too much, and we can fix it and bring it back down. The other ones I would consider increases in hormones, but not to where, we're trying to bring them down to get them under control.
Cool. Thank you.
Yep. What else? I did that. Okay, let's see. Dun, 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 8:35, we're good on time. So we did that. Thyroid infection. I'm so sorry, Will. Sure. Anything that's going to disrupt the function of the thyroid, potentially will alter the way that it receives messages from the pituitary and how it produces the hormones. And so if it is an actual problem with the thyroid, if there's an infection of the thyroid, then that would be a primary cause. My guess is with an infection, the thyroid is not going to function as well. So it would probably be, we would have decreased levels of hormones. So probably a hypothyroid situation. Excuse me, but I'm not the doctor. I don't know that for sure, but that would be my guess. Okay, how about, can we move on to parathyroid? Or more questions, or think of questions, and we can come back to questions. We'll move on to parathyroid information. So parathyroid glands, these little teeny tiny glands, there's 4 of them, kind of behind your on the backside of the thyroid. And they basically regulate calcium and phosphorus, but we're going to focus more on calcium. Again, you can have overactive parathyroid glands, or you can have underactive parathyroid glands. These are a couple good videos that talk about the calcium balance with that. Again, Nurse Mike has some really, really good ones as well. And what basically happens is we want calcium, right? We want calcium for bone growth. We want there to be the right amount, when we check our labs in our blood, right? And what regulates that is actually the parathyroid glands. And so they will help to, if we have a low calcium, they'll help to release calcium from the bones. They can have reabsorption from the kidneys to get more calcium into the bone. So if you have hypoparathyroidism, because there's not as much parathyroid hormone, you will have low calcium in the blood. If you have hyperparathyroidism, you have more parathyroid hormone, which means in turn you will have more calcium. So you have hypercalcemia. So one of the things that we look for, you may have heard, or I don't know, of Trousseau's or Vostok sign. I don't know if anybody's heard of those or seen those, or I know 1 or 2 cohorts ago, somebody actually saw them doing the testing. Hunter's heard of that? Okay. Yes. Oh, good. Okay. And so this is what, for these purposes, yes, there are other times when you can have hypocalcemia, but we are focusing right now on the parathyroid glands and hypocalcemia. So Trousseau's is a spasm, like in the hand. You can put the blood pressure cuff on, and it's actually, if you look, there's videos on YouTube, different places, and it actually, like, the arm's fine. Like when you take somebody's blood pressure, it's fine, and then it slowly but surely just sort of like curls up in the hand, and the whole hand starts to like fold over. That has to do with the muscles. It's like it's a spasm that we're causing. And then Bostic sign is contraction of the facial muscles. You tap on the facial nerve, kind of like on the cheek under the eye, kind of. And then you get a twitching of the lip or spasm of the facial muscles. And so those are some things that you want to look at. There's Trousseau's, there's Fostex. And as you move into multi-system failure and other ways of losing calcium, hypocalcemia or hypercalcemia, and if you have too much or too little, that can also then backtrack to the parathyroid.
I have a question, Mrs. Solinger.
Yes.
So you're saying for hypoparathyroidism, you would have hypocalcemia. Is it true that with that comes inverse relationship of having hyperphosphatemia?
Yes. Hyperphosphatemia.
Phosphatemia.
Yeah.
Okay.
Yeah. Because calcium and phosphorus are opposites.
So in terms of like your test, with this concept, you would want us to be just familiar with hyper and hypos of these two things, like
Yep.
the calcium and the phosphate,
Yeah, not levels necessarily, but
like the effects.
you know, yeah, like the effects of hypocalcemia, what you see with hypocalcemia, maybe which test would you try? If you suspect they have hypocalcemia, what's another good one? For thyroid, I might ask you about the medications, signs and symptoms, and interventions for those potentially.
Okay, thank you.
And when we do the Sully Sesh before the exam, I'll try to get more specific as I can, related to the specific things that I want you to know and understand. I think there's 4 questions, 4 or 5 questions. So generally speaking, I try to do one for hypothyroid, one for hypoparathyroid, and then one on growth hormone. And then if we go back to the objectives and kind of look through those, not that one. That's not what I wanted. Where did it go? Oh, yes, it is. From the study guide that you have, right? It's what are the risk factors? How do you know, like, what are the signs and symptoms that someone, for example, has hyperthyroidism, and then what's the worst thing that could happen, right? Or hypothyroidism, or maybe they have constipation and they're cold all the time. What imaging or what labs maybe do you think the provider might order? Does that make sense?
Yes, it does. Thank you.
Okay. Okay, so yeah, so this was the what to know. Right, this is what I gave you already, the positive and negative feedback loops, which we talked about. So it might be, sometimes I'll ask, to not to provide an example, but give you an example. And is that a positive or negative feedback loop? Not going to ask anything on congenital hypothyroid, so we can take that one out. Signs and symptoms of hypocalcemia. What happens if parathyroid hormone is high or low? What happens if T3 and T4 or TSH are high or low? Mostly the post-op care, I'm thinking in terms of if you do a total thyroidectomy, can you leave the parathyroid glands there? That's not a question I would ask, but I think it's kind of an interesting concept, because the problem is that you take a gland out, or an adrenal gland, or you take out the pancreas, right? Then you are on lifelong hormone therapy. What else was I going to show you? Let me bring this over. maybe not. No, maybe not. Wrong way. No, that's. Oh, my Word has just not been working today, and it is very frustrating. I was basically going to show you the study guide that I just put up for you. So there's like a basic one with objectives, and then I tried to kind of like I did with the previous ones, like tried to fill in even more information for you. There it goes. Yay. So this is the one that I just posted. Can you see that on your screen? Is it the hormone guide, the study guide, or is it still the PowerPoint or the lesson? No, you can't see it. All right, hold on. Let me stop sharing and then I will reshare. One moment, please. Let's see. That is not what I want to do. More share. Share. Dun, dun, dun. Entire screen. Yeah, that should be the one, right? Didn't know that one. What do you see on? Oh, no, you have to hit share, Janine. There we go. What do you see now? Yeah, there we go. Concept of hormonal regulation. Is that what you see now?
Yes.
Yes. Okay. So this is just a little more in detail of the what to know for hormonal regulation. So again, examples of negative or positive feedback loops, talking about what the job for the hypothalamus pituitary gland is. Again, just focusing on the thyroid and the parathyroids, but this might help you when you get to Addison's and Cushing's and ADH, those types of things when we're talking about the adrenal glands. And then there's risk factors, talks about primary versus secondary, different lab values. So for example, we were saying, what if it's hypothyroid, it's an increased TSH, decreased hormone, glandular hormone. There's your phosphorus, right? Decreased calcium, increased phosphorus. And then the growth hormone is the deficiency would be a decrease in growth hormone. This is a insulin mediated growth factor something. I don't need you to know that. And here's again signs and symptoms of hypocalcemia, different lab levels to know, which is what not specific numbers, but why we're looking at those particular labs. So these are the things that are based on the objectives. And then we talked about post-op care. We're talking throat, right? So besides the long-term therapy, things that we are worried about at the bedside, coming back to like post-op, right? Pre and post-op, airway, right? Airway. And then the hypocalcemia, there could be sometimes you can catch the laryngeal nerve, like the voice box. So sometimes there can be voice issues. Yeah, importance of regular lab follow-up. There's the medications. Again, I think I'm going to take out, well, you guys can make your own copies and do what you would like. I'm not worried about all these other markers and all that. These are just other labs that are available. The radioactive iodine would be good to know. And again, I don't really care about those things. The calcium and vitamin D kind of work well together. The D3 actually helps with the calcium moving into the blood, which is kind of cool. And then this kind of just gives you for the initial screening. If it goes one way, you do this. If you go another way, it goes that. And then you have a whole section on growth hormone. And so if they have, let's see, yeah, and that's in the anterior pituitary. So it's just giving you just that risk factors, clinical features, basically just short stature, what you would monitor, education, as well as there's the growth hormone excess. So again, I will go over specifically where I want you to focus even more so. But this is just, I think it's a nice study guide. It gives you information. So you have that available to you now as well. Other than asking what specific questions will be on the final, do you have other questions, concerns, things I can potentially answer for you? Do you want to look at one? Somebody's kiddo. Let me see. That's not what I want. Trying to see if I have like a quick case study that we could go over.
I had a question.
Yeah, David. Mm-hmm.
I was looking at your study guide and I saw that PSH would be up when calcium is also high, in opposition to the way that the T3 and T4 would be with TSH, where
Oh, where they're opposite. Yeah.
yeah, why is
Because that's the way the glands work
that?
with the feedback with the feedback loops.
Okay, that
Because
one's
you
opposite.
will have yes, and you will have different feedback loops of positive or negative depending on the gland. Right,
so the
'cause you actually-
parathyroid, that's positive then, and the thyroid stimulating is negative. Is it?
Yeah, because you've got opposites. It's doing an opposite thing. If I increase the parathyroid hormone, it will increase my calcium, and that keeps going. So that would be a positive. That'd be like the oxytocin one. If my TSH is high, my other hormones are low. So I increase my hormones, which then I'll decrease my pituitary stimulating hormone, which would be a negative feedback. Bless you.
Right. Thank you.
Yeah. And
I
all
got
the glands are different. Mm-hmm. What else? Questions? No, let's see. No. Let me see. No, I guess that, I mean, I don't want to keep you too late because many of us have clinical early in the morning. Is there anything else? Hopefully this was a little bit helpful, at least give you something to sort of focus on a little bit more. And we didn't have the lecture on it, so this is what I would have done in the lecture. So I think I will go ahead and stop the recording. I'll stop recording. Stop recording. And then I will